Our next speaker is none other than Dr. Chitra Ramamurthy. She'll be speaking about biometry in post-refractive surgery.
Very good morning to one and all of you, and thank you very much, Dr. Shaji, for this invite to be included in your course. So, biometry is actually a complex topic, and post-refractive surgery makes it that little more complex, because the challenge here is that these patients have enjoyed that visual independence before when they got the refractive procedure, and would want similar, and would even be ready for enhancements if they are stuck somewhere. So essentially, we all know that today the way the cataract surgery stands, it's not just rehabilitative, but it's also a refractive procedure, wherein more than 80% of the patients are actually within plus minus 0.5, and 98% of them are within plus minus 1 diopters of target refraction if there has been no refractive surgery done. But the outcomes become challenged if there has been a refractive surgery done and you come for a cataract surgery. Now, what is the challenge? Why is it that the IOL power calculation is so difficult after refractive surgery? And the next question comes, what is the accurate way of calculating the IOL power? So the essentially reasons for residual post-op errors is axial length measurements, and we have now standing at this stage where it's an unsurpassed accuracy with the different optical biometers which we have. So the other challenge is the keratometric errors. When we talk of keratometric errors, it could be a keratometric index error, an instrument error, or an extrapolation of ELP. Now, keratometric error, like if the feed in the radius of curvature, it has to be converted to the power in diopters, and this is the formula which is being used, where n, which is the refractive index, is a fictitious value of 1.3375, which was arrived at so that an average eye of 45 diopters, the radius is equal to the power. But it also assumed that the ratio of the anterior to the posterior curvature is 82%. Now, all of this gets altered in a refractive surgery, which is a point to note. Now, all the earlier calculations of IOL power was based on the surmise that the cornea was a spherical cornea, whereas in post-LASIK, myopic LASIK, it becomes a little oblate. In a hyperopic LASIK, it becomes hyperprolate, and in post-RK, the central cornea gets flatter. The other error is the instrument error. What happens is, whether we are using a manual K at 3.2, or you're using an IOL master with 3 rings, or your lens star, what happens is that you are not able to measure the most central part of the cornea. So all the measurements are paracentral, and you're assuming on the central value. So what happens in a myope, the paracentral cornea is actually a little steeper than the central cornea, which is very flat. So you end up overestimating the K and underestimating the IOL power, and you end up with a hyperopic surprise. The other issue is the problem of the extrapolation of ELP. Now, based on the Fyodorov's concept, the ELP was measured based on the curvature K of the cornea and the height and the corneal diameter. Height is distance from the corneal surface to the implant center. Now, if the IOL is placed little in front, it needs a lesser power. If the IOL is sitting a little behind in the capsular bag, it needs a higher power. So that much difference comes if the effective lens position is not accurately measured. However, the Aramberry's double K method and the other newer methods which have come in, like Haig's cell formula, they do not rely on the K by pre-op K, but they rely, and in Haig's especially, uses the anterior chamber depth to arrive at the ELP. So there have been modifications with the newer generation formulas. So the next question comes, what is the solution which you're going to offer? This by estimating the corneal power, either with the total keratometry or the pentacam EKR or the Galilease. So in total keratometry, using a toric model to measure the anterior corneal surface, and with the help of the swept source OCT and B scan, you're extrapolating the same points on the posterior cornea and getting a total TK. But we also need to remember that in all those calculations, Hoffer Q, Holiday and everywhere, they have derived a mathematical method of estimating or assuming the posterior corneal astigmatism. And if you add this total TK to that, you could end up with an overcorrection. The other one is the pentacam EKR value, where it gives us the K value at different optical zones. Again, it can be used in those formulas which use the Holiday report. It can't be used in double K Aramberry's formulae, or it can't be used in Haigis, which have used a different methodology of measuring the K value. And then is the Galilee's, which is a ray tracing method, which takes it to a different level of accuracy. So the solutions are then not using formulas that extrapolate K. So then you could look at the ASCRS calculator, wherein one, you know the pre-op K, but either you have the surgical induced change known or it's not available. And based on that, the different choices are coming because of the limitation. I'm not going into the specifics. However, again, at this point of time, the Haigis uses a corrected corneal index. So what it does is, that is what is incorporated in its formula, and it is not relying on the corneal curvature at all, and so there is no way it is going to extrapolate the ELP. The ASCRS calculator earlier had the pre-op corneal details and the refractive change, and then only with the refractive change where there was no prior data, but it was seen that in less than 60% of the cases only, you were within plus minus 0.5 diopters. And then what it used to give was an average value and what would be the least or the max value, and you needed to decide that you can overestimate K in a myope, so use the lowest value. You can underestimate K in a hyperope, so use a higher value. But then the recent ASRS calculator has done away with the group 1. It only has group 2 and group 3, and definitely goes without saying that the OCD derived formulas are way ahead. So in the ASCRS calculator, you can go into prior myopic, prior hyperopic, prior K values and feed in all the datas, and then it gives you the minimum and max. You can do it similarly for the hyperope and it will give you the minimum and max. Whereas in Barrett True K, the specific thing, it is using a mathematical model which is not told to us, where it calculates a modified K, and it also uses a double K solution. That is, it uses a pre-op K of the prior refractive surgery and uses the post-op K, and then thus it makes its calculation in the Vergennes formulas. So herein again, you need to feed in the LASIK mode, need to enter all the details which are asked, and it is seen in Abu Lafia's study that the Barrett seems to be doing extremely well within plus minus 0.5, 1 diopter and 2 diopter of predicted accuracy. And again, literature also says that the Haigis, the Hill, RBF and the Barretts are doing well in more than 90% of the cases. A word about radial keratotomy is, we know that the vision is fluctuation because of the diurnal variation refraction and the progressive hyperopic shift. We also know that you think that the cornea is flat and you inaccurately estimate the ELP to be a little forward, which is not so. We also know we need to measure right in the center of the cornea in a radial keratotomy, which is not possible. So the IOL power calculation, what they do is, if it is, you add half a diopter if there are 4 incisions, add 1 to 1.5, there are 8 incisions, and add 2 diopters if there are 12 or more incision. And again in ASCRS calculator, you can do the post-RK calculation, but be prepared that you will need for the eye to stabilize till the transient hyperopia goes. Post-smile is much better because of more favorable keratometric and aberrometric values, and even the EKR value shows a good peak. So are the aberrations study, which shows. The last slide which I have to tell you is, so in post-RK, you can use a true K toric. For a myopic classic, if you remember that you are inducing positive spherical aberration, so you use a negative spherical aberration IOL, and most of our IOLs are negative spherical aberrations. For a hyperopic classic, we need to remember that you are inducing negative aberration, so use a positive spherical aberration like a Sensor 3-piece IOL or an aberration-free IOL of Bausch & Lomb, and if it is an irregular aberration, use an aberration-free lens. So in conclusion, what I would like to say is, we need to conceptualize that there's an error going to happen in K value, in keratometric measurements, in ELP, we need to remember that we need to use the solutions or the latest formula which have given us an alternate approach. And if you thoroughly understand the science behind biometry, we would be able to do still well with all our post-refractive surgery patients who come for a cataract surgery. Thank you very much.
Thank you, ma'am. Wonderful, enlightening talk. Any doubts regarding this presentation? Okay, ma'am. Thank you. Our